Dear Dr. Menge, today we want to talk about the diagnosis of soft tissue sarcomas. And of course, before the patient even reaches you, they must have already gone through various other doctors who suspect enough to send them to the hospital. And so my question is, what are the symptoms that a patient or a person experiencing these symptoms should be aware of and consider that it might be a soft tissue sarcoma?
Well, that's a bit tricky, because sarcomas can occur anywhere in the body, and depending on where they occur, they can also cause different symptoms. The most common places where sarcomas occur are the extremities, so arms and also the legs. When the sarcomas occur there, patients usually notice a swelling. Usually, there is no pain associated with it, and the swelling usually grows. Sometimes, if they are located deep in the tissue, you might not notice the swelling initially, but you may simply notice that the overall size of the leg increases, and for example, you really notice that the pant leg becomes a bit tighter. When sarcomas occur in the abdominal area, they often don't cause any symptoms. So then the patient might notice, my waistband is getting tighter, or I have to loosen my belt, but I haven't really eaten much more. The waistline increases a bit, but usually he doesn't have any other symptoms. So, what we sometimes have with other types of tumors, these warning symptoms, like this fever over 38 degrees Celsius, night sweats, weight loss, we have that extremely rarely in sarcomas. Sometimes they just have a feeling of pressure in the abdomen, or they go to the doctor for a completely different examination, and it's just an incidental finding. That's why it's very difficult to say, unfortunately, there isn't really a typical symptom for a sarcoma.
That makes it all the more difficult, right? I think that's probably exactly the problem. Since sarcomas are already so rare, or soft tissue sarcomas are so rare, that neither patients, as well as I would say, various doctors don't even think of it, you know? Yes, that's why. We've already spoken. There are really quite different doctors who are then confronted with a question from a patient who says, I have symptoms, X, Y, and Z. What kind of doctors might be confronted with sarcomas in the first step?
Basically, of course, many, but actually the general practitioner is probably the first point of contact. And there are certain warning symptoms that should perhaps also alert the general practitioner. But the problem is, of course, sarcomas are very rare, and a general practitioner might only see 1 or 2 sarcomas in their entire career. This means it's important to consider it.
Oh, okay.
And thinking of a sarcoma in these rare cases is really difficult.
Yes, sure.
In England, doctors have made an announcement where they said, anything larger than 4 centimeters that grows, that is located deep, so it cannot be easily moved, for example. These, and maybe also those that cause pain, but not always, are warning symptoms where you should be alert and consider a sarcoma. They once sent a golf ball with a writing on it, for example. That could be, for instance, a sarcoma. In that case, the golf ball is about 4 centimeters, a bit bigger, and that might be a good reminder. And these are the warning signs that might wake up the first doctor who sees this patient a little. Of course, it is incredibly difficult to think about, which also means that the diagnosis is often made so late.
I once talked a bit with some patients, and they really listed all sorts of things like general practitioners, but also often orthopedists, apparently, because there are somehow some problems with the legs. Skin apparently too? What is there? What could there be with the skin, possibly, that occurs there?
It could just be this swelling. Most soft tissue tumors are benign, like a lipoma, and you think this is something soft that can be easily moved, and it could often be a lipoma. Dermatologists, for example, also see that. But sometimes it can also be redness, for example.
Just to mention briefly, a lipoma is made of fat tissue, right? Like under the skin, above the muscle, fat tissue.
Exactly. Usually soft, well-defined, and easily movable. Dermatologists will notice it immediately. but there can also be a redness over it, or it can present itself in very different ways. Yes. And when the patients go to the general practitioner, he usually first does a blood test, which he often does. Ideally, he should first examine the patient, which he should do, palpating it. And then often a blood test is done here. But the tricky part is that you often don't find any clear signs of sarcomas. So, normally the blood values completely match. Okay, so there's nothing indicating it. And there are also no tumor markers like there are for other tumor-oriented journeys. But there's no such thing for sarcomas either. With sarcomas, you really have to be careful. If you realize, I have something growing that has a certain size, and sometimes you can also, to document this size, because it is somewhat subjective too, we have some patients who were very clever and said they simply place a ruler next to the spot they noticed. For example, we had another check within 2 weeks, again with a ruler. Of course, one can document it. Either it grows or it doesn't. That way, you avoid the subjective feeling and can tell the general practitioner, something is growing here. Please take action.
And if it grows inward, is it then possibly worth comparing the limbs? So from what I know, comparing the left thigh with the right one.
Yes, of course. But that can also be individual again. You can measure a centimeter and adjust, and after 2 or 3 weeks, measure again and say, something's happening here. And then it has already been objectified, and you can work with it better in some way.
That's a tip that could also be given to general practitioners, to do that sometime.
Right now, this photo documentation, that's something that's truly very effective.
Now, we did say that it always takes a certain amount of time before patients show up here with you. From what kind of doctor are the patients generally sent here to the sarcoma center for further examination?
The whole range, ultimately. On the one hand, these are really the general practitioners who determine this, who often think further and say, yes, we're also going to do further imaging now. Maybe they have already done an ultrasound and can see a tumor that they can't quite categorize, which they might not like, which is also perfused, in contrast, for example, to a hematoma after bumping into something or something like that. And then often a diagnosis is already initiated by the general practitioners, which also helps us a lot, because we don't have to start there, as the appointments are not so quickly available. And then, you often see in the MRI, and the report states, soft tissue, mass, or something like that. And then, with this, patients often come from general practitioners, but also from orthopedists, or sometimes from internists, from gastroenterologists, if it is in the abdominal area, or from gynecologists. But the fact is, especially general practitioners, who are the first point of contact for patients.
Yes. So, personally, I would also wish that general practitioners occasionally use an ultrasound on the extremities, because I believe this is something general practitioners don't naturally do, as they always think they need to look at the organs with ultrasound. But I believe that if there is a tumor, it can definitely be seen on the ultrasound, right?
You can see it too. You don't have to classify it, but you can get a bit of a feel for it, or use it for measuring. If the general practitioner knows the patient well and says, this is new, what you have, then it's something else. But if the patient doesn't know the general practitioner well and says, was this here before? The patient says, I'm not quite sure. I always think it's very important to objectify and not always rely on this feeling, this gut feeling. It is super important to trust your gut feeling, but especially in situations like this, it sometimes just helps to simply measure it out and say, this is how it is now, and in 2 weeks, this is how it will be.
Yes, perfect. Wonderful. Exactly, you already made a brief remark. That means imaging is often the critical next step, and typically a magnetic resonance imaging is done.
It depends a bit on where the tumor is ultimately located. So if it's on the limbs, then the MRI is more suitable because it allows for better delineation, or better delineate the structures from each other. In this way, one can better distinguish the tumor from the muscle tissue and the surrounding tissues, such as blood vessels or nerves. This is very good in MRI. MRI is also usually performed in the abdominal area, but even then, there's always the question, when do I get an appointment? Because MRIs are just not as widely available as CT scans, and the appointments take a long time. That's why, especially in the abdominal area, CT scans are often still leading in primary diagnostics, and everything in the chest area, CT scans are usually still leading there too.
Okay. Also, MRI means magnetic resonance imaging. And I don't know, I think these days, many people probably have had it done for various reasons. Maybe we should say a few more words about it. It's a tube, a long, long tube where you lie down inside. And I think something that is quite uncomfortable for patients is that it's loud. And that means, so to speak, there would be a hint. So first of all, my personal approach, when you drive into the tunnel, just close your eyes. Because it is very narrow. I have to say, I actually find it very...
And only open it again when you're out.
When you're back outside. Exactly. And if the people helping you, the assistants, forget about it, make sure to have ear protection to definitely protect your ears. Because I think it's really this banging. I must admit, I don't really know why this banging happens, but it's really loud and I find it kind of unpleasant, and it also takes a while to get it done. Half an hour at least. Yes, indeed.
Exactly. Depending on what needs to be defined. Exactly. Exactly what you said. The confined space. Nowadays there are open MRIs, but especially the confined space. And if one has a larger body type, then it is really tight. Sometimes I really wonder how well some patients endure it. It's so close to the head. It's really close. And you can hardly move. Exactly. It takes some time. It's loud. And your tip. Just close your eyes and get through it. That's exactly what I see. And really, only open your eyes again after and firmly tell yourself, I will only open my eyes again when I drive out again. Otherwise, you might feel a sense of confinement in there.
Yes, that's true. But I think you have to. So these are our tips and tricks for the patients. And I also believe, conversely, you can say, you always have this bell in your hand. And if you really say now, I really can't stand it anymore, then you can ring it and you'll be taken out, and so on and so forth.
And some MRI scans do it too. They give a calming pill beforehand. Some do that too. But it's definitely worth sticking it out. Because the final result of an MRI, when you see how beautifully sharp you can really judge the different layers, then it is really worth it. Of course, it's also a matter of staying still.
Yes,
That's another
right.
thing, because otherwise we have these shifted images, which also makes it difficult. But yes, if you manage to do all that, then it really is worth it.
And I think an important point that we should discuss again is the contrast agents. They are important because the body is somehow full. There are so many structures, and one wants to clearly distinguish one structure from another. And that's why these contrast agents, I have to say, I have no idea how they work, are definitely injected into the bloodstream. Now, there are patients who are somewhat concerned about, whether it could be harmful to health.
The question keeps coming up. But the real added value we get from the contrast medium is clear, especially in the initial diagnosis. Then you can always have a chat with the radiologists about whether they really need a contrast agent every time. But if you know what you're looking for and can focus on that, then it's easier than when you have just the initial scan and have to first figure out, what am I looking for? And where is the tumor located? And how is the tumor positioned? That's why contrast medium is especially important, particularly during the first CT and eventually with the MRI as well.
Exactly, because the result of where the tumor is, how big it is, and so on, is truly an essential part of the diagnosis.
Exactly. And above all, it's very important to clarify everything at the beginning. Also, when the contrast agent enters the body, it gets warm.
Oh, yes, that's right. Yes, that's right. That's a strange feeling.
Yes, exactly. When you go into a tight tube, it narrows and heats up. You also get scared.
It is good to know that beforehand, because then you're informed and won't get upset. Yes, exactly. Exactly wonderful. Then there is this CT or computed tomography, and it indeed uses X-rays. So I personally find the image giving itself more pleasant, because it's a relatively open, narrow tube that works very quickly. That's it.
Yeah, exactly.
Right?
You lie on the table,
Exactly.
They move you in and out, and then you're done.
But the disadvantage is the radiation.
Exactly. It's radiation exposure. That's why there are efforts to keep reducing the radiation exposure. These so-called low-dose CT, which is also done in progress diagnostics. In lung cancer, it is the same that when screening for lung cancer in smokers, for example, this low-dose CT with very low radiation exposure is used. Especially for the first examination, a proper CT scan with contrast agent is absolutely more important to me when the question is, for example, do I have a metastasis in the lung or something like that? In this case, the radiation exposure is less important to me at the moment. Everything done afterwards, such as follow-up care, when one does it, for example, is different. Once the tumor disease has been overcome, you can discuss everything. But especially at the very beginning of the diagnosis, these examinations should simply be optimal in order to have an optimal picture of the patient.
And what comes out of it then? So let's say now you have the images and they're all nicely sectioned. That means you can really see all these layers within the body. What is actually the result? Can you already say if it's benign or malignant? Or is that not yet possible at this stage?
Radiology has come a long way and can already make assessments. Often, they can already tell us, yes, there is a suspicion of a malignant soft tissue tumor. They can already compare that with symptoms like circulation issues and so on, based on various weightings and stocking. We can already give an assessment and express our suspicion. But it is just the suspicion, and that ultimately cannot be the final diagnosis.
How does it continue after imaging? What are the next steps?
In the ideal case, the patient would present themselves to a specialized center following the imaging.
Exactly. Very important point.
Before I continue, this is very, very important. Now it's crucial again to set the course. We just need to be able to give the thing a name. Without knowing exactly what we're talking about, we can't plan the best treatment, and all further steps depend on it. And that's why this step is very important, because you simply need fine tissue from the tumor. You need a sample of the tumor that can be processed, and now it must be planned how to obtain this sample.
So I'll try to briefly say in easy words, there's something in the body, and if you really want to know exactly what it is, you have to take a small piece out. That's what is meant by fine tissue. You take a small piece out.
Exactly. You just need a small sample of the cells that make up this tumor, or from the entire tissue actually, that makes up this tumor, in order to reliably investigate it, and then to be able to advance optimal further planning, and first of all, really substantiate the diagnosis that the MRI, for example, raised as a suspicion.
Yes.
Exactly. And then there are different ways to obtain this sample. The least invasive is really the ultrasound, or CT-guided core biopsy.
So biopsy is a term used when you take a bit of tissue, right?
Exactly.
Okay. And what does core needle biopsy mean?
That means you have a specific device and use ultrasound or CT to see exactly where, because that is also important with tumors. Tumors are not the same structure everywhere, but sometimes there are areas with more cells. Sometimes there are areas where it somehow falls apart. Sometimes there are cavities in there. That means you have to look at where you take the sample from. Ideally, you plan this either based on the available imaging, such as a CT scan or MRI, or based on the ultrasound. Where exactly do I go? Because you want to get the right spot on the tumor, the most malignant one, if it ultimately turns out to be a malignant tumor. Okay. And then you look at where most of the cells are located and what the blood flow is like and so on. There are various criteria, so that it is planned to take the sample exactly from that spot.
So basically, it's obvious that you want to try to cause as few injuries as possible, right? That's why you really go there with such a thin tube, right? We also have a picture of it. Actually, it almost looks a bit like a syringe and so different.
Yes, exactly. There are different systems. But the most established one now is a system where first the needle is really shot out, and then a sort of sheath is shot over it, allowing one to really obtain a cylinder from the spot that is ideally the most significant. And all of this is done without causing the patient pain and without harming other things. That's why it's done in a controlled manner, either with CT or ultrasound guidance, depending on the situation.
And that means afterwards, so how does one have to imagine it? It's really like a little worm,
Then
isn't
you
it?
have these little worms. You try to get 3 to 4 of these nice little worms, exactly. Then you look at them to see if they are really compact, or if maybe not. Maybe there is just some mushy tissue there or whatever. But then you can look at it and say, yes, those are beautiful cylinders. We can also send them to pathology for further examination. And then, of course, we check again to make sure there is no rebleeding or anything like that. And of course, it is numbed locally beforehand so that it
That
doesn't
is
hurt.
self-evident. Yes, exactly.
Exactly. Yes. And then the tissue obtained can ultimately be further processed in pathology.
So now it was said that these little worms come out during the punch biopsy. But I think sometimes the patients are also afraid that when you have to pull the device out again, you were inside the tumor before, then you pull it out again, that perhaps some tumor cells are dragged into the channel, which could then possibly lead to further growth in another location.
Yes, that's a common fear among patients. And of course, it can't be completely ruled out, but based on the data, it's really very, very unlikely. A very low single-digit percentage, if at all. Also, it's important that such a biopsy is carried out in consultation with the surgeon. Because usually, if you eventually start thinking about surgery for the soft tissue tumor, then the channel you went through is also removed. So in the surgery, the tissue that could possibly be contaminated is also removed. And that is also so important in this planning that you take all this into account beforehand. And if possible, this should also happen in consultation with the surgeon, or at least you should be able to tell the surgeon later, I went through this, and please take this tissue with you.
Oh yeah, that's obviously good to know that it's done that way. In pathology, well, there are the experts who then look at those cells. But really visually, right? That means you look at it visually?
The first impression they have is looking through the microscope and thinking, what am I actually looking at here? What type of tissue do I have in front of me? And then they take many more steps. They color the material. They may also need to do further examinations. Nowadays, you can also examine the tumors or the cells genetically and see what changes you have there. And then, we have to add up all these little clues so that in the end, you can tell us, yes, it is a soft tissue tumor. It is a malignant soft tissue tumor. Ideally, please also be able to classify them, because there are now over 100 different types of sarcomas, and they sometimes require different treatments or ultimately have different prognoses. And that's why it's really important that the pathologists can tell us, what type of sarcoma is this? But then the sarcomas also have different, malignant behaviors. So some divide very slowly, some more. Some, yes, have more potential to metastasize, others not. And you really have to bring it all together to get a complete picture of it.
And that's why it's so important to really do it at the Sarcoma Center, because it's certainly a very high art that can really only be done by experts to know and recognize these over 100 different forms, right?
Yes, that is one thing, having the pathologists who know about it. One should have seen rare things frequently to classify them well. And even if one center cannot do it, then the sample is sent to another center, and a second pathologist looks at it to see what it is about. And exactly, ultimately, what defines a center is that people who deal with this disease on all levels. These are the pathologists, but also the surgeons, radiotherapists, and oncologists all come together in what is called a tumor board. In an interdisciplinary tumor board, a joint decision can be made on how to proceed, and the earlier one goes into such a center, the better. A diagnosis can become clearer and ultimately important for the patients, setting the course for further procedures.
I think another really important point is that we've been talking about a tumor the whole time, but there are patients who might already have metastases. That means you don't know. You know there's a tumor, but you don't know if there are metastases. So there's a second round where that's specifically checked.
Yes, that's when the diagnosis is really confirmed. And that is also another thing that is a very difficult time. From the time of removal of the sample until it is ready, it can sometimes take 10, 14 days. Because certain coloring methods simply have to be done, which are also not done every day and so on. Or you may really have to send it away again. So this is a time that is very, very difficult for patients because this is the waiting time. And sometimes you can fill it by having the patient also gets a bit out of the passive into the active by telling them, okay, please take care to get appointments for imaging of the lungs because sarcomas, the main site, the place for sarcomas, for metastasis, is, for example, the lungs. And the appointments are usually not tomorrow either. Then you can tell patients, make sure you get an appointment for a CT scan, so that if it is confirmed to be something malignant, one can also, as soon as possible, can look around to see if there are metastases, and then can get into therapy more quickly and plan the therapy. And these are also possibilities to get the patient involved in the action again by saying, okay, we definitely need this. Appointments can be canceled if necessary. You're not really supposed to say it out loud, but that's how it is. We want to know sooner where things are headed. If there are metastases, the better we can plan quickly for the patient.
That means when the diagnosis is complete, then it's known whether it is a soft tissue sarcoma, of what type it is, how malignant it is. Apparently, there are also such gradations or whatever, and above all, whether there are metastases elsewhere or primarily in the lungs. That means it is really clear how the therapy can proceed. So the therapy is basically derived from what came out of the diagnosis or what?
Exactly. When you have all of that together, ideally, this board meeting takes place where all the specialists who deal a lot with this type of tumor sit together, because you can then move into the planning of the therapy. And then you have to estimate. You have to estimate what the first step is and what the second step is. And for all that, it is important that, for example, one does not operate immediately. When there is a diagnosis, the first idea is, there is a tumor and it has to come out. It scares me, it has to come out. But that is often not the best decision, even if you have the lot, but perhaps certainly a therapy that could be advanced to, for example, make an operation better, or completely remove the tumor, because then it perhaps has not been done beforehand. And all that, to decide whether, for instance, one should have therapy before surgery. You can only do that if you have all the steps in place beforehand and have put all the little pieces of the puzzle together. Then you have comprehensive information. Having all the information up to date is essential to plan the optimal therapy. That's why it's such a shame when surgeries are done quickly. But of course, it's understandable that one would want the tumor removed immediately. However, it's really worthwhile to take the time to do this.
Thank you very much, Dr. Menge. I think we really got a very, very good overview of how the diagnostics work. We also want to really delve into the individual soft tissue sarcomas, and in the following film, we will discuss the specific diagnostics once again. Thank you very much.
Very gladly.